Thank you for allowing me to present here today. Jody was mentioning my interest. My main research interest is in inflammatory bowel disease. But today I'm here to discuss gastrointestinal cancers. So I'll start by, these are on this slide you can see the different types of GI cancers that there are. However, discussing all the cancers that are listed on this slide are beyond the scope of this talk, as we only have about an hour to cover the topic. Therefore, I'll discuss the most common GI cancers, which are highlighted on the slide, which include colorectal cancer, esophageal cancer, gastric cancer, liver cancer, and pancreatic cancer. Can I just have a show of hands of anyone who's had either a personal history of gastrointestinal cancer or someone who actually a first degree relative who has? Okay, so about 50% of you. Now this slide just shows the gastrointestinal tract. And so if you look at the slide, this is the esophagus. We'll be talking, or the food pipe, we'll be talking a little bit about esophageal cancer. This is a liver which drains some of the toxins from your body. So we'll be talking about hepatocellular or liver cancer. The esophagus drains into the stomach, which we'll be talking about, stomach cancer. Then the stomach goes into this long, small intestine, which then goes into the large intestine, which you see here, and then into the rectum. So we'll be talking about colorectal cancer. And then this is a pancreas, which sits, which overlies the stomach, and it's responsible for secreting some of the digestive enzymes, as well as secreting some hormones like insulin, which controls our blood sugar. So we'll be talking about pancreatic cancer as well. So just to outline what we'll be discussing for each cancer, we'll be talking about the risk factors, some of the symptoms and signs that each cancer presents with, how each cancer is diagnosed, some of the screening guidelines for the cancers, and then the treatment, the basic treatment. I won't be discussing the treatment at length, but just because, again, it's beyond the scope of this talk, but some of the basic treatment guidelines and some of the chemotherapeutic agents that are used and the treatment modalities that are used. So we'll begin with colorectal cancer. And this is an important cancer because this is one of the GI cancers that we actually screen for, and screening is recommended in everyone. So colorectal cancer is the fourth leading cancer in the United States. There are 150 yearly diagnoses of colorectal cancer. It's the third leading cause of death from cancer in the United States, causing about 50,000 yearly deaths. So some of the risk factors for colorectal cancer include age, so that your risk increases as you get older. And then in terms of race, African Americans have an increased risk. And the screening in African Americans is actually recommended to start at 45 years of age instead of 50, which is the age that's recommended in everyone else. If you have a personal history of colorectal cancer, you have an increased risk of developing cancer at another site. So your risk is about 3% to develop it at another site within the colon. Then patients who have a history of polyps called adenomas or adenomatous polyps, they also have an increased risk of developing colorectal cancer because those types of polyps are precancerous. Patients who have a history of inflammatory bowel disease, particularly ulcerative colitis, have an increased risk of colorectal cancer. There are some genetic syndromes, such as familial adenomatous polyposis, or FAP, and Lynch syndrome, which predispose to developing colorectal cancer. FAP is actually a disorder where patients have oftentimes greater than 100 polyps within their colon, and almost all of those patients get colorectal cancer by the time they've reached 30 to 40 years of age. Some other risk factors include alcohol. So those who consume 2 to 3 drinks per day have an increased risk. Smoking is a risk factor. Patients that consume a lot of red meat have increased risk. Patients that are obese, they have 1.5 times risk of developing colorectal cancer. Then a condition called acromegaly, where you secrete too much growth hormone, is another risk factor. Patients that have had kidney transplants are at increased risk. Patients with diabetes have slightly increased risk, and also patients with coronary artery disease have increased risk. Most patients with colorectal cancer are asymptomatic, meaning they don't have display any symptoms at the time of diagnosis, and it's just caught when they're screened on routine screening, when the patients have their first colonoscopy. And then some symptoms that can be there include rectal bleeding. Melena is another symptom that patients can present with. Melena means black-colored stools. Abdominal pain. Some patients complain of a change in bowel habits. This is particularly true for patients who have cancer towards the end of their colon. Because of the obstructing lesion, it causes your stools to become thin. Then unexplained iron deficiency anemia is another sign of colorectal cancer. And then oftentimes patients who have rectal cancer, which is cancer all the way at the end of your colon, complain of rectal pain, urgency, and again, thinning of the stools. And then in advanced cases, patients can have obstruction, symptoms of obstruction, where they have nausea, vomiting, severe abdominal pain, constipation. So now coming to, so once colorectal cancer is suspected, the diagnosis can be made by colonoscopy. The advantage of doing a colonoscopy when you suspect colorectal cancer is that one can take biopsies during the colonoscopy, which is needed to make the diagnosis. Another test that's often done is a barium enema, which a dye is inserted rectally and then basically a barium enema. So the dye is given via enema, and then simple X-ray pictures are taken. And then a CT scan. So this picture here shows a CT scan, and there's an obstructing lesion here. So this is here, which is a cancer. And then here you can see a colonoscopy, and the cancer is actually here. This is a normal part of the intestine, and this is in contrast to this picture, which is a normal appearing colon. So there's tumor markers also that are often used to diagnose colorectal cancer. However, it's not recommended to check. So the CEA is specific for colorectal cancer, but it's not recommended to check the CEA in everyone to be used as a screening tool. The reason of this is because the CEA can be elevated in other conditions such as gastritis, peptic ulcer disease, diverticulitis, liver disease. So the main use of the CEA is to determine the prognosis. So once we diagnose a colorectal cancer, we often check the CEA, and a high level, especially greater than 5, is indicative of a worse prognosis. It's also used to monitor patients when they're being treated. So we check a baseline CEA, and then a patient's treated by either surgery, chemotherapy, or radiation. And then the CEA should come down. And then if you monitor the CEA periodically, and if it's coming back up, then that gives us a signal that maybe the cancer is coming back. This slide just outlines the staging of colorectal cancer, and a similar staging system is followed for most cancers. So it's called the Tumor Node Metastases staging system. So basically, there's 3 things that we look at. We look at the primary tumor, and so we're looking at the size of the tumor and also what it's invading. So for colorectal cancer, T1 is called the tumor is essentially when the tumor invades the submucosa. T2 is when the tumor invades the muscular layer. If it goes beyond the muscular layer into the areas that surround the colon, it's a T3. And if it has distant spread, then it's a T4. And then regional lymph node is a node component. N0 means there's no lymph nodes that are involved. N1 means 1 to 3 lymph nodes are involved. And then N2 is 4 more regional lymph nodes. And then distant metastases, M0, which means no distant metastases, and M1 is distant metastases. So oftentimes when we describe a tumor, we'll often say T2, N0, M0. We'll refer to it like that. Now, coming to colorectal cancer screening, there's different modes of screening. So they're classified into early detection of colorectal cancer, which include the stool tests. So there's a fecal occult blood testing and the fecal immunochemical testing, or FIT testing. Then there's prevention of colorectal cancer, which are the structural tests, and those include the flexible sigmoidoscopy, colonoscopy, and then now, which is relatively newer, which has come up in the last 10 years, a CT colonography, or a virtual colonoscopy, as it's also referred to. So the fecal or stool occult blood testing, the newest one is a Hemoccult Sensa, which has a sensitivity of 64 to 80%. And if you have a polyp, the sensitivity of diagnosing that is 40%. So as you can see, this, its ability to detect polyps is not that great, only about 40%. There's a newer test, which is a fecal immunochemical test, which are more specific than the previously mentioned guaiac-based testing because they only respond to human globin. And so these tests don't detect any upper GI source of bleeding. They specifically detect bleeding from the colon. So the sensitivity of this test is a lot more, so it's 61 to 90% for colorectal cancer. For adenomas, it's still 20 to 60%, so it's still quite low. So the pros of the stool-based tests are that they can be performed at home, they're non-invasive, and they're cheap. But they have several cons. One is that they're mostly geared towards early detection, meaning that they'll be positive once one has developed a cancer. And they're not often positive when one has adenomas or precancerous lesions. Another drawback is that they need yearly testing. So oftentimes we find that patients don't follow up with yearly testing. It's not easy to do at home. Flexible sigmoidoscopy is another mode of screening. This test, if one uses this test, it's done every 3 to 5 years is the recommendation. So this picture shows, this is a picture of the colon, and when you're doing a flexible sigmoidoscopy, the scope only goes up to about here, so the left side of the colon, or about 2 feet into the colon. And so you're missing this entire area here. The yellow depicts where when you're doing a colonoscopy, the scope reaches all the way to the end of the beginning of the colon right here. So the advantages of flexible sigmoidoscopy are that the prep is often simple. It's not like when you're doing a colonoscopy. It just involves doing a simple enema. No sedation is required for the flexible sigmoidoscopy, which is advantageous because there's less risks associated with sedation. The complication rate is very low, so it's only 3 in 10,000. It can be an office-based procedure as well. The disadvantages that I've already mentioned is that the entire colon is not examined. And then, so any cancer that's on the right side of the colon, they can be missed. And then if one does have cancer that's detected on flexible sigmoidoscopy, say in the left colon, then oftentimes those patients need a full colonoscopy just to make sure they don't have another cancer growing on the right side, because as you know, that all these patients who have a cancer at one site could be at risk of developing another cancer at another site. So this is a slide showing colonoscopy. Colonoscopy utilizes a long tube called a colonoscope, and the procedure takes about 30 to 60 minutes. And the preparation involved is that the day before the procedure, you have to be on a clear liquid diet the entire day, and then your doctor prescribes a bowel preparation, and there's several available that one has to take the night before the procedure.
Have they improved that at all?
In terms of the preparation?
Yeah, how miserable it tastes and all that.
Yeah, so I mean, gradually there are improvements. There's newer and newer preparations, and also patients often don't like the taste. Is one disadvantage, and then the volume. So the volume is a lot. So now there's newer preps where the volume is not so much, and they're better tasting. So some of the preps you can mix with any type of fluid that you want, such as Gatorade. But I mean, it is still onerous to drink a large volume. So that's one of the drawbacks of a colonoscopy. So an advantage of doing a colonoscopy is that the precancerous lesions that I mentioned, such as pictured here, so this is a polyp, this can be removed while we're doing the colonoscopy. This is a picture showing how we remove the polyp. So this is a endoscope or colonoscope, and through the endoscope we put the biopsy forceps, which you can see here, and we sort of grab the polyp, and we can remove the polyp. If there's large growth, such as cancer, we can take biopsies with the same forceps. So the sensitivity of detecting colorectal cancer with the colonoscopy is much higher than the fecal test that I mentioned. So it's 88 to 96%. And then the sensitivity for detecting the precancerous polyps is also much higher than the fecal-based tests. So if a polyp is greater than 1 centimeter, it reaches up to 99% the sensitivity. If a polyp is 6 to 9 millimeters, sensitivity is 84 to 95%. If it's less than 6 millimeters, it's 75 to 85%. So the advantages of a colonoscopy are that it allows full visualization of the colon. It can be both diagnostic as well as therapeutic because, as I mentioned, we can remove polyps during colonoscopy. It's also considered the gold standard test by major gastroenterology societies. It's recommended by the American College of Gastroenterology as well as the American Society of Gastrointestinal Endoscopy. The disadvantages are that a full bowel prep is often required. It requires sedation. So we ask that most patients, when they do come in for a colonoscopy and they're sedated, that somebody drive them home, and also that they probably should not work that day. So it's missed work also. And then it does have, although the complication rate is low, the complication rate of major complications is 0.3%. But it's still higher than the other tests. Now, coming to a CT colonography or a virtual colonoscopy. So basically, in this procedure, computer simulated endoluminal perspective is given, and it's similar to a CT scan. So here you can see some of the images. It gives you very nice images of the colon, similar to what you would see when you're doing an actual colonoscopy. But this test is often reserved for patients who are unable to have a colonoscopy because of the various disadvantages. The pros of this procedure are that it's less invasive and has a lower, obviously a lower complication rate. The disadvantages are that these patients still require the same bowel prep as a colonoscopy. This procedure is associated with a high false positive rate. So oftentimes patients have stool that are clinging to the wall of the colon, and that could be mistaken for a polyp. And then there's limited sensitivity for polyps that are less than 1 centimeter in size. If the test is positive, then the patients will require a colonoscopy for removal of the polyp because these polyps are precancerous. And then the final drawback is a radiation exposure. So you get a lot of radiation associated with the scan. So the radiation is almost about 400 times that of a regular chest X-ray. So it's a lot of radiation. And then I didn't mention on the slides, but another form, recently FDA, another form of screening that was approved by the FDA actually in this month, earlier in February 2014, was a pill cam. So it's like the capsule endoscopy that's used for to evaluate the small bowel. There's a type of pill that's available to look at the colon as well. So that involves swallowing a small pill, and that the pill actually takes pictures of your colon. But because it's not very sensitive, it's only reserved for those patients who are unable to have colonoscopy. And I actually have an example of a couple pills you could pass around. Take a look.
So these are brand new?
These pills? These are dummy pills, actually.
But this has just been approved?
Yeah, it was approved February 4th, I think, by the FDA.
So have you done one yet?
No,
I was
no.
gonna say, it's just a couple weeks.
Yeah, yeah. So summary for colorectal cancer. The age that you start screening, it's recommended to start at 50 years of age for everyone. As I mentioned before, for African Americans, the age that you start screening is 45 years of age because they're at increased risk. Also, if you have a family history of colorectal cancer, you start screening at the age of 40 years or 10 years before the diagnosis of colorectal cancer in relative. So whatever comes earlier, either the 40 years or 10 years before the diagnosis of your relative. The different screening modalities that are available are as colonoscopy, which is recommended every 10 years, a CT, colonography, or a virtual colonoscopy, which if you have that done, it's recommended every 5 years, a flexible sigmoidoscopy, which is recommended every 3 to 5 years, and then if you're doing the stool-based test, they're recommended every 1 year. So the treatment of colorectal cancer, and this is just, again, a basic summary of the treatment. So when surgery is done, it's done with the hopes of curing a person of disease. And the second instance where surgery is done is if the cancer is causing a lot of symptoms and to relieve those symptoms to make a patient more comfortable. If cure is not possible, then excuse me, chemotherapy is considered. And then the different modes of chemotherapy that are done are palliative chemotherapy. Palliative, it means that when any cancer, not only colorectal cancer, is advanced and has already spread to other parts of the body, the goal of that type of chemotherapy is to shrink the tumor to make a patient's life better, more comfortable, and hopefully prolong the life as well. Adjuvant chemotherapy means that it's chemotherapy that's given after a tumor is removed. And then neoadjuvant chemotherapy is chemotherapy that's given prior to removing the cancer, to shrink the cancer before removing the cancer. And then the types of chemotherapeutic agents that are used are 5-fluorouracil, which is given with leucovorin, Xeloda, which is an oral form of 5-FU, and that's essentially used when the colorectal cancer has spread to other organs. And then some other newer agents are listed, which include Camplostar, and then radiation is also used. There's also biologic therapy, and these substances do not directly destroy the cancer, but they're able to trigger the immune system basically to fight your cancer. And an example of one of these agents is Avastin. So now moving on to esophageal cancer. So again, this is your esophagus or your food pipe. There's 18,000 new cases of esophageal cancer per year. There's 15,000 deaths. There's two types of esophageal cancer. One is squamous cell cancer. That usually occurs in the upper half of the esophagus. And the major risk factors of squamous cell esophageal cancer are smoking and alcohol. And then adenocarcinoma is another type of esophageal cancer. That usually occurs at the distal or the end of the esophagus just before it goes into the stomach. The major risk factor of adenocarcinoma of the esophagus is reflux, and which oftentimes can lead to Barrett's esophagus. So again, to mention the risk factors for esophageal cancer, they include smoking, alcohol, gastroesophageal reflux disease, which can lead to Barrett's esophagus. Another risk that's not mentioned on this slide is Oftentimes patients will consume like alkali substance such as bleach or other caustic substances, and they have a very high risk of developing cancer a few years after that. So the symptoms of esophageal cancer, one of the main symptoms includes dysphagia, which means difficulty swallowing. And the reason why you have difficulty swallowing is because you have the tumor that is causing obstruction to your food pipe, and so food can't pass. So patients initially complain of difficulty swallowing solids, which then progresses to liquids. Other symptoms include weight loss, bleeding from the tumor, pain. The pain can often radiate to the back, so patients say I have pain in my mid-chest that's going to the back. Hoarseness of voice, cough, and then respiratory symptoms mostly occur because the food contents cannot go down and they're coming up and they're going down the airway, causing cough and other respiratory symptoms. Weight loss is seen in about 50% of patients. So the diagnosis of esophageal cancer is by an EGD or esophageal gastroduodenoscopy, which is similar to a colonoscopy, but this is when we have a tube, a flexible tube with a camera attached to the end of it, and it's passed down into the esophagus, stomach, and then just the upper part of the small intestine. So that's, again, the advantage of doing a EGD is that you can do biopsies at the same time. And again, biopsies are needed for diagnosis to confirm. Once a patient's diagnosed with the cancer, then one has to stage the cancer to see how far it's spread, if at all spread. So staging is done by doing a CT scan, a PET scan, or endoscopic ultrasound. And an endoscopic ultrasound is basically a test where you have an ultrasound probe attached to the end of the endoscope, and it allows us to see other surrounding structures. So if you pass it into the esophagus or the stomach, you could take a look at the structures that surround the GI tract. And so say if a tumor is spread outside the food pipe, say in like a lymph node, you can take a biopsy with the endoscopic ultrasound tube. So in terms of screening for esophageal cancer, routine screening is not recommended in the general population. So the reason for that is that screening would result in no or minimal decrease in death as a result of screening. So that's why it's not recommended. However, it is recommended to screen to see if patients have a condition called Barrett's esophagus in certain individuals who are high risk of developing esophageal cancer. And so basically, if patients have or are age 50 years and older, are males, are white or Caucasian, have chronic reflux symptoms, and are obese, those patients should be screened for Barrett's esophagus. A little bit about Barrett's esophagus, because this is a risk for developing esophageal cancer. So this is essentially when the normal squamous epithelium, or the lining of the esophagus that we have, because of chronic irritation from reflux or acid exposure, the lining changes into a different type of epithelium called columnar epithelium. And again, it's due to chronic GERD or reflux. And these patients have an increased risk of developing esophageal cancer. It's small, ranges from anywhere from 0.1% to 2%, various studies have quoted. but they are at increased risk. So patients, once a patient has been diagnosed as having Barrett's esophagus, it's recommended to do the EGD, or upper endoscopy, every 3 to 5 years in those patients, just to monitor the Barrett's, make sure it's not turning into cancer, and taking biopsies. When there's low-grade dysplasia, which actually means early signs of cancer within the cells overlying the, or within the confines of the Barrett's esophagus, it's recommended to do an EGD every 6 to 12 months in those patients. And then certain individuals have high-grade dysplasia, and in those patients, generally it's recommended to treat those patients. And there's various modalities to treat high-grade dysplasia and Barrett's. And then if one is not treated, then it's recommended to do an endoscopy every 3 months in those patients. So the treatment of esophageal cancer, stage 1 disease, where it's not spread, particularly T1A, is by endoscopic mucosal resection. So this is where we're resecting the tumor endoscopically, so using the endoscope, basically. And then in more advanced lesions, such as T1N1 or T2 to 3, with any nodal involvement, patients are given chemotherapy. So this is neoadjuvant chemotherapy before surgery, and then radiation. And then this is followed by complete removal of the esophagus. And the chemotherapeutic agents that are used are, again, 5-FU and cisplatin. Stage 4 disease is just treated with chemotherapy, so surgery is not done. And in these patients, it's mostly palliative chemotherapy.
What do you do if you take someone's esophagus out?
So that's a good question. So when the esophagus is taken out, then you do what's called a gastric pull-through. So you pull the stomach up and connect it to the proximal, or the beginning of the food pipe. And so the stomach actually acts as a tube. So you're essentially losing your stomach, but so there's no reservoir to hold food, but so you have the stomach that's acting as the food pipe or esophagus that goes into the small bowel. So that's what's done. That's a good question. So now coming to gastric or stomach cancer. There are 21,000 new cases of gastric cancer per year, and then it leads to about 15,000 deaths per year. And there's various types of stomach cancer, but the most common type is an adenocarcinoma, which occurs in 85% of stomach cancers. 15% of cancers can be lymphomas or GIST tumors. So the risk factors are, as you get older, and it commonly occurs in patients in their 70s. Males have twice the risk as females. In terms of race, African Americans and Asians have an increased risk. Also, patients from parts of Central America and South America have increased risk. Patients, particularly from who grew up in Japan, have an increased risk. And then patients with blood type A, for some reason, have an increased risk of developing stomach cancer. Family history of stomach cancer doubles to triples the risk of getting stomach cancer. And then smoking and alcohol are again implicated in stomach cancer. And then patients that consume a lot of salted smoked or nitrate preserved foods are at increased risk. And then H. pylori, so a bacteria. H. pylori is a bacteria. And if one has a H. pylori infection of the stomach, you're at increased risk of getting gastric cancer.
What would you consider the large amount of salt in smoked food?
So, I mean, that's a good question. I don't know if that's ever been determined how much, but I think generally people who consume such foods on a daily basis would be at increased risk. And I think that's one of the thoughts why it's so common in Japan, because of consuming such foods in Japan a lot. But I don't know the quantity. So a word about Helicobacter pylori. This is a spiral-shaped bacterium that's commonly found in the lining of the stomach. It can cause gastritis, it can cause peptic ulcer disease, and then it can even cause cancer. So approximately 20% of people under 40 years old and approximately half of adults over the age of 60 have H. pylori. It's thought to be food and waterborne. And the diagnosis of H. pylori is based, there's several ways to diagnose. Could be a blood test. There's also a breath test. You could check for H. pylori in the stool. And then you can also, when you're doing biopsies of the stomach, when you do an EGD, you can detect H. pylori as well. So just to clarify, not everyone with H. pylori will get cancer. It's still very rare, but it's still a risk factor. And then, question?
If you've had H. pylori and it's been treated, is there any indication that you're more likely to get it again?
So then I don't think so. Usually it's an active infection. Wait, I'm sorry. Your question is when you're get H. pylori again, or
Are you more
get?
likely to get H. pylori again?
Oh,
if you've had it once?
No, you're not more likely to get. And then the treatment of H. pylori is generally, there's many different regimes that can be used, but it's taking a combination of a proton pump inhibitor, such as a medication like Prilosec, Nexium, Prevacid, in combination with 2 to 3 antibiotics that you take for 2 weeks, and then that should treat the bacteria. Oftentimes there is resistance, so the initial treatment generally works in 80% of people. But if it's, what we often do is we check patients to make sure they're cured. So we recheck them after about 8 weeks after treatment to make sure that the bacteria is not still there. Symptoms of gastric cancer include, common symptom is indigestion, bloating, loss of appetite. Early satiety is another risk, which essentially means that you get full really fast after eating. Nausea and vomiting could be other symptoms. Vomiting blood, heartburn, abdominal pain, especially in the epigastric area or the area just below your sternum. Weight loss, blood in the stool, which because it's in the upper GI tract, by the time it reaches your, your colon, it makes your stools black. And then symptoms of anemia, so fatigue, difficulty breathing are other symptoms. To diagnose gastric cancer, if one suspects gastric cancer, again, an EGD with biopsies is used. An upper GI series can also be used, which it's a test that involves swallowing a dye, either barium or gastrographin, and then taking pictures. And the dye essentially goes in your esophagus, stomach, and then small intestine. We can view all those structures. Once the diagnosis is made, again, we do staging with the same tests that were discussed before. So they include CT scan and a PET scan. So screening, in the US, there's no screening program for gastric cancer, so it's not recommended for the same reasons why we don't screen for esophageal cancer. Because the prevalence is so high in countries like Japan, Venezuela, Chile, they do have screening programs, and they often use barium studies as well as upper endoscopies to screen. And then, again, it's not cost effective to do screening in the US. So preventing one gastric cancer death would be estimated to cost about $247,000. So the treatment of gastric cancer, if it's very early and it's very early stages, we can just like esophageal cancer, we can resect it endoscopically, which is called endoscopic mucosal resection. And then if you're attempting cure, again, surgery is indicated. Surgery is called gastrectomy. If the tumor is towards the end of your stomach, you could remove part of your stomach or a partial gastrectomy. If it's in the middle of your stomach or more proximal at the beginning of your stomach, then it's a total gastrectomy, so you remove the entire stomach. I've listed some of the chemotherapeutic agents that are used. So these are some of the older chemotherapeutic agents that are used in stomach cancer, some of the newer agents that are used here, and then combined with radiation. So patients that have regional disease, stage 1 to 3 disease, is potentially curable, and it's often a combination of all three: surgery, chemotherapy, and radiation. And then for stage 4 disease, again, it's palliative, so you use a combination of chemotherapy and radiation to treat. So skip this slide. So now coming to liver cancer. Liver cancer is the third leading cause of cancer deaths worldwide. It's highest in Asia and Africa. And the reason for this is because of the high prevalence of hepatitis B and C in Asia and Africa, which are the major risk factors for liver cancer. In the US, the incidence is not high compared to other cancers, but it's actually increased over the last 2 decades. So it's increased from 2.6 to 5.2 per 100,000. So the risk factors are, again, Asian Americans and Pacific Islanders are at increased risk. And again, that increased risk is because of the high prevalence of hepatitis B and C in those individuals. Alcohol abuse is a major risk factor for hepatocellular carcinoma because these patients can develop cirrhosis of the liver, which alone is a risk factor for hepatocellular carcinoma. Having chronic hepatitis B or C, which are viral infections of the liver, are risk factors. Hemochromatosis is a hereditary disease which is associated with too much iron in the liver, and that's a risk factor. There are other hereditary diseases of the liver, such as alpha-1 antitrypsin deficiency, Wilson's disease. Those are also risk factors of developing liver cancer.
Explain what those two. My mother died of liver cancer, and that's the only place she had it. It didn't.
Okay.
Mm-hmm. So what were the two diseases you just mentioned?
So there's many hereditary diseases, like metabolic diseases. So there's Wilson's disease, in which there's too much copper in the body. And so copper deposits in many organs, such as the liver. It's a disease where you're not metabolizing the copper properly. And then alpha-1 antitrypsin deficiency is another deficiency that you have, which predisposes to getting emphysema and then also liver cirrhosis. So it's a deficiency of a particular molecule. And these are all hereditary diseases.
Could one get tested for that?
One could get tested, but it's not routine. So say if a patient has elevated liver function tests, and then and it's unexplained. So that, say if they don't have the initial testing that we do for those for elevated liver function tests are we assess to see if the patient drinks too much alcohol, make sure they don't have hepatitis B or C, and if those are not true, then we start looking for other more obscure causes, such as the ones that I mentioned. So it's not, or if you have a family history of, say, alpha-1 antitrypsin deficiency, then you could talk to your doctor about testing for it. But it's not recommended to screen everyone for the deficiency. Then aflatoxins are also risk factors. These are cancer-causing substances made by a type of plant mold, and that have been implicated in liver cancer. Aflatoxins can contaminate wheat, peanuts, rice, corn, soybeans, particularly in developing countries. So I don't think it's much of a concern in this country. Smoking is another risk factor. Obesity, which causes fatty liver disease and then can also cause cirrhosis, is another risk factor. Anabolic steroid use is another risk factor. So the symptoms, a lot of patients are asymptomatic, meaning they don't have any symptoms when they're diagnosed, and it's often diagnosed as part of routine screening when we're screening high-risk individuals. And then the patients that do have symptoms, oftentimes they'll have pain in the right upper quadrant or pain in this area where the liver is. Weight loss is another symptom, as is with a lot of other cancers. And then when patients have decompensated liver disease due to the cancer itself, they might have symptoms like jaundice, itching, confusion or ascites, which means swelling of the abdomen, leg swelling. So the diagnosis is by abdominal ultrasound, oftentimes a CT scan, MRI, or angiography. Now, in terms of screening or surveillance, so screening is not recommended for healthy individuals, so it's not recommended for the general population. However, certain patients with risk factors, excuse me, it's recommended that what we call surveillance of those individuals for hepatocellular carcinoma. So patients with hepatitis B are at particular risk. So it's recommended that Asian men over the age of 40 years, Asian women over the age of 50 years, that we regularly monitor for hepatocellular carcinoma. All hepatitis B patients with cirrhosis should be regularly monitored. And then also Africans and North American blacks should be monitored regularly. Patients with a family history of hepatocellular carcinoma should also be evaluated regularly. And then any patient with cirrhosis, regardless of the cause, should be evaluated regularly for hepatocellular carcinoma. And now when I say regularly, that means that every 6 months, it's recommended that we do both an ultrasound and alpha-fetoprotein, which is a blood test that's increased, or a tumor marker that's increased in liver cancer.
What tests do you do for that? You said they should be tested.
Yeah.
It's the ultrasound?
So the ultrasound and then a blood test, which is the alpha-fetoprotein. So that's in anyone who has cirrhosis, regardless of the cause, and then in most individuals with hepatitis B. The treatment of liver cancer is a little bit different than other cancers because there's many different treatment modalities. One is surgical resection if the tumor is small, and if it's amenable to surgery, then surgical resection could be considered. Liver transplantation is another mode of treatment of liver cancer. But in order to have a liver transplantation, you have to meet certain criteria. So there's something that we call the Milan criteria, which means that the hepatocellular carcinoma, if it's in only one location, it has to be less than 5 centimeters. And if it's in 3 different locations of the liver, each lesion has to be less than 3 centimeters to be listed for transplant. That's called the Milan criteria. There's also different modes of ablation of the tumor, which means burning off the tumor. And that's used for smaller tumors. So one mode is radiofrequency ablation, or microwave ablation is another one. And then there's also chemoembolization, which means that you intentionally clot the hepatic artery or the artery that's supplying the tumor. And then there's radiation, and then there's systemic chemotherapy, which is a drug. The agent that's used is sorafenib, which is oral drug, which is used, and it's oftentimes used in those patients who don't have resectable disease, who we're basically using for palliation or palliative care. Now, the last cancer I'm going to talk about is pancreatic cancer. This is a cancer which oftentimes has a poor prognosis, and it's often diagnosed at late stages. So surgery is the only curative treatment for pancreatic cancer. And surgery, unfortunately, is only an option in 15 to 20% of cases. There's about 46,000 new cases per year. This type of cancer is more common in westernized countries. The 5-year survival rate of pancreatic cancer, even after surgery, is only 25 to 30%. So the risk factors are mostly genetic for pancreatic cancer. So if you have a family member with pancreatic cancer, your risk is about 1.5 to 3 times that of the general population. There's some patients who have hereditary pancreatitis. These patients have an abnormality of the PRSS1 gene. These patients often start getting episodes of pancreatitis starting at the age of 5 or 10 years of age. And then the BRCA and BRCA2 genes, which are genes, as you all know, implicated in breast cancer, those patients also have a high risk of developing pancreatic cancer. And then another gene called the PALB2 gene is also another risk factor. There's a syndrome called Peutz-Jeghers syndrome, which is a condition where you develop lots of polyps in the colon. Those patients have an increased risk as well. There's a familial atypical multiple mole melanoma, which is another hereditary syndrome, and those patients are at increased risk. Excuse me. Lynch syndrome, which I talked about a little bit before, and FAP is a condition where, again, your colon has a lot of polyps. Those patients are at increased risk of developing pancreatic cancer. Ataxia telangiectasia is another condition that predisposes. Lifestyle factors, again, smoking is implicated. Obesity and lack of physical activity are also implicated. A westernized diet with high intake of saturated fat and or meat, particularly again smoked or processed meat, predisposes to pancreatic cancer. Fresh fruits and vegetables are actually protective for pancreatic cancer. And then heavy alcohol consumption has been implicated. Not listed on this slide, but there are some studies that have shown drinking lots of coffee increases the risk, but there's other studies that have shown that there's no risk for with drinking coffee, so it's controversial. The symptoms that patients have are pain in the mid-abdomen that travels to the back, jaundice, weight loss, anorexia or loss of appetite, nausea and vomiting, dark urine, or steatorrhea, which is stools that have a lot of fat. The diagnosis can be by abdominal ultrasound, which is highly sensitive for detecting any bile duct dilatation, which you can get with pancreatic cancer. And oftentimes an ultrasound may show a pancreatic mass that's seen. CT scan can be used in the diagnosis also. Special type of CT scan called a triple phase contrast enhanced helical CT is done, which is more specific, gives us better images of the pancreas. And then ERCP can also help diagnose pancreatic cancer. And MRCP, which is an alternative to ERCP, can also help diagnose. This test gives us a good idea about the anatomy of the bile ducts as well as the pancreas. Endoscopic ultrasound, which I mentioned before, is good at visualizing the pancreas through the wall of the stomach. And the same test can be used for taking biopsies through the stomach with a small needle. So routine screening is not recommended in average risk individuals, but routine screening is recommended for certain patients who have these hereditary conditions. So they include patients with Peutz-Jeghers syndrome, patients with hereditary pancreatitis, individuals that have 3 or more first, second, or third degree relatives with pancreatic cancer. Patients with these genes, so the BRCA genes, they should be screened. These 4 genes that are listed, these are positive in patients who have Lynch syndrome, which is predisposes to colon cancer. They should be tested. And then sometimes on routine imaging, we oftentimes see cystic lesions in the pancreas. One of them is called the IPMN, and then another one is called Pannin lesions. And those patients are at increased risk, so it's recommended that we screen those individuals. So screening, there's no consensus on the appropriate test for screening, which test should be used for screening, and also there's no consensus on the interval of screening, so how often should we screen these individuals. But oftentimes physicians choose about 6-month intervals as screening the individuals who are at high risk, and the different tests that can be used for screening are CT scan, MRI, ERCP, or endoscopic ultrasound. This is a picture just depicting, again, the endoscopic ultrasound. So this is the ultrasound, this is an endoscope. It has an ultrasound probe at the end of it. And it's pictured here again. So it's giving us an image of the pancreas that sits behind the wall of the stomach. And then this is a needle. So you could put a needle through the scope and take biopsies through the wall of the stomach of the pancreas of any tumor that's seen. So the treatment for pancreatic cancer, surgery is possible if there's no, essentially if there's no spread to surrounding structures, and especially no spread to the blood vessels that are surrounding the pancreas. And then chemotherapy can be by, is essentially for both unresectable as well as resectable cancer. And these are the agents that are used. And then radiation therapy is often combined. So just to summarize, essentially, or the different modes of prevention are, you can't change your genes, but there are certain lifestyle factors that one can do. So avoid smoking, because I think smoking was implicated as a cause in all of the cancers that I mentioned. Avoid heavy alcohol consumption. Red meat should be consumed in moderation. Exercise is important. Weight loss if one is overweight or obese. And then I think follow up with your primary care physician on a regular basis is essential. And if you have any unusual symptoms, then you should always tell your physician. And then follow up with screening guidelines, I think is important. So everyone should be screened for colorectal cancer. And then the other cancers you should be screened for if you have a condition that deems you high risk for developing those cancers that some of the high risk conditions that I discussed. So just wanted to share this slide with you. This is my son and my wife and son. So any questions that you guys may have?
You had mentioned shortness of breath in relationship to, 20 minutes ago on the slide. Could you please tell me where that applies to gastro cancer?
So I had mentioned respiratory symptoms as part of a symptom of esophageal cancer. And so the respiratory symptoms can be cough, difficulty breathing, even chest pain when you take a deep breath. Those are all respiratory symptoms. The reason why you may get respiratory symptoms with esophageal cancer is that the obstruction that it's causing, so the food actually comes up, and then you aspirate it, so it goes back down the windpipe, and so causing an infection of the lungs, which can cause, or pneumonia of the lungs, which can cause respiratory symptoms. The other way you could get respiratory symptoms with esophageal cancer is sometimes a tumor invades the esophagus to the surrounding structures, so it can actually invade the trachea, which is your windpipe, so it can create a connection between the esophagus and your trachea, called a tracheoesophageal fistula. So that's another way you can get symptoms, respiratory symptoms from esophageal cancer.
Speaking primarily here of colorectal cancer, you mentioned possible relationships or spreads of cancers, one type of cancer to another, and I'm thinking particularly of a possible relationship between colorectal cancer and prostate cancer.
Mm-hmm.
Can one lead to the other?
Sure. So colorectal cancer, to repeat the question was, does colorectal cancer relate to prostate cancer in any way? So they're both distinct entities, and they don't relate to one another. And colorectal cancer usually does not, to my knowledge, does not spread to the prostate. But good question. And then the prostate, oftentimes when you see your physician for an annual exam, it's oftentimes you'll have a rectal exam. Males will have a rectal exam. to feel for the prostate. So the prostate's easily felt through the rectum with a finger. But again, the two cancers are different entities. They don't relate to one another.
But prostate cancer is known to metastasize to various parts of the body.
Exactly, yes.
But would colorectal area be one of those?
Does the prostate, I believe it's rare to spread to the bowel itself. Yes.
Yeah, I have a question about esophageal cancer.
Yes.
Should I had it, should my children be checked out? When should they start being screened or talk to their doctor?
So I believe, as far as the society recommendations, I think there's no recommendation for if one has a family history of esophageal cancer, there's no recommendations for screening those individuals. However, the guidelines for screening individuals who have reflux, so screening those individuals for Barrett's esophagus is relatively loose. The guidelines are quite loose. So if you have many risk factors or a few risk factors, then one can justify doing upper endoscopy. So if your children have symptoms of reflux and they have some risk factors that I had mentioned, such as being overweight, being over 50 years especially, males are at increased risk, having a history of smoking. So all of those in the presence of reflux, then a doctor should consider doing a upper endoscopy just to rule out Barrett's. And if one has Barrett's, then you should monitor that on a regular basis. If one doesn't have Barrett's, then again, you can stop and you don't need to do endoscopies. Next question.
Is it common for a fistula to develop between the two organs, or with everything being so close? Is that a chance that you might develop a fistula between one or the other?
Sure. So the question was, can one develop a fistula between two different organs? And so if everything's fine, all our organs are packed in our abdomen in a small space. If you don't have a cancerous process or any inflammatory process, then forming a fistula is very rare. Almost impossible to develop. But then if you have cancers that have spread outside the organ, outside a wall of a particular organ, then it can form a fistula to an adjacent organ. Then other causes of fistulas include if you have inflammation. So a common area is if one has diverticulosis and develops an infection, like diverticulitis, they can develop a fistula to different organs like the bladder. If one has inflammatory bowel disease, especially Crohn's disease, one can develop a fistula as well to surrounding structures.
Now, would that be, once you develop a fistula, would you just have palliative care, or is there a means of being able to?
No, it's often surgical. There are surgical treatments for. Again, it depends on what the fistula is due to. If it's a cancerous process, it's often surgical. If surgery is safe to do, then it's often surgical treatment. If it's due to an inflammatory process, like Crohn's disease, then you treat the Crohn's and the fistula might close on its own. If it's due to an infectious process like diverticulitis, then you treat the diverticulitis and follow. Other questions? Yes?
What do you think about cleanses? Cleansing your liver and your bowels?
Yeah, so the question was, what do you think about cleanses of your bowel and liver? So, I actually don't believe in cleanses. Oftentimes they claim that the cleanses remove fat from your colon, and that's theoretically not possible because the colonic wall doesn't have any fat lining or anything. So it's just clean mucosa which is impossible. So I don't believe in cleanses. So other than the prep for the colonoscopy, I think that's a cleanse. But, so, yes.
What do you think of the benefit of a high fiber diet with all of these
Yes. So
cancers?
yeah. So I think a high fiber diet is a good thing. It prevents against, a lot of studies show that it helps against forming diverticulosis, for one. And then in terms of cancers, it's been implicated in reducing chances of pancreatic cancer, colon cancer. So I think it's beneficial.
Could you address diverticulitis or diverticulosis a little bit?
Sure. So diverticulosis is a condition where pockets form in the colonic wall. It's quite common, and about 50% of the colonoscopies that I do, I see at least some pockets or some form of diverticulosis. Two major complications of diverticulosis include bleeding. When they do bleed, they cause a lot of bleeding, so you'll know it, usually causing hospitalization. Another complication is diverticulitis, which means that there's an infection that occurs within the pocket itself, and that usually causes pain in the left lower side, and oftentimes patients need antibiotics to treat. Other questions? Yes.
The stool test you mentioned, is that ill-conceived if you have hemorrhoids?
Yeah, so hemorrhoids can cause false positive on this. Yeah, so that's another drawback. That's a good point. Other questions? Yes.
Is there any link to any of the colorectal cancers if you have a history of spastic colon or colitis?
So the question was, is there a link to colon cancer and spastic colitis, spastic colon and colitis? So to having a spastic colon, there's no link. Spastic colon, what do you mean by spastic colon? Do you mean?
I've heard that as a diagnosis when somebody has a lot of.
Oh, okay. Spastic colon may refer to irritable bowel syndrome. One of the thoughts is to have spasms of your bowel, one of the causes. And so there's no link between colonic spasms and cancer. And then colitis, so there's different forms of colitis. So ulcerative colitis, which I mentioned, those patients are at increased risk of developing colorectal cancer. Patients who have ulcerative colitis involving their entire large intestine, the recommendation is that we screen those individuals with colonoscopies every 2 to 3 years, starting 8 years after the diagnosis. And then Crohn's disease, patients who have Crohn's colitis, so Crohn's disease involving their colon, the same screening guidelines are given. And then there's other forms of colitis which don't have, like microscopic colitis, they don't have an increased risk of developing colorectal cancer. And then there's infectious colitis, which is a short bout of diarrhea that you may have when you have an infection of the colon. Those individuals are not at increased risk. So, other questions? Yes.
Can you recommend a good medical website for us to look into our problems further?
Sure. So WebMD is a good medical website. That I think that's pretty good, comprehensive.
Is that the best one out there?
So I've seen WebMD, and then the Mayo Clinic website often has good information for patients as well. So those are two sources.
Okay, do you practice at UCLA or are you out at Las Vegas here?
I'm actually out at, so there's a UCLA office in Porter Ranch. I'm there primarily.
Are you ever out here?
I'm not, so I have privileges at Los Robles Hospital, so I see some inpatients if they get admitted and if they need a GI consult. So I'll see those patients. But my practice, I see outpatients in the Porter Ranch area. There's a UCLA office in Thousand Oaks and also in Westlake Village. I have colleagues that work there, but I myself don't see patients in those two offices.
That's a shame.
Do you see an increase in gastrointestinal cancers now that so many people are doing resections just to lose weight? Have you seen an increase in?
So the question is, are we seeing more GI-related cancers because of resections? So you mean resections in terms of gastric bypass?
Yes.
We often do see complications of gastric bypass, like such as ulcers, but I don't think they increase your risk of getting cancer. At least, I mean, I think this procedures are being done for the last at least 20 years, and we're not seeing increased, to my knowledge, increased cancer in those patients. And yes.
One last question.
Yeah.
Most recently, I've been hearing links from colorectal cancer and breast cancer.
Mhm.
Can you speak to that a little bit?
So I mentioned the BRCA 1 and 2 genes, and those patients who have the BRCA genes are at increased risk of developing other cancers besides breast cancer. So ovarian cancer, they're at increased risk. I believe uterine cancer, and then colorectal cancer as well. They're at increased risk of developing. So they should obviously be screened. Other questions? Okay, thanks a lot. Thank you.